Our next speaker is Dr. Aasim Padela. So Dr. Padela is the director of the Initiative on Islam and Medicine. He's an associate professor of medicine in the section of emergency medicine and a faculty member of McLean Center for Clinical Medical Ethics at the University of Chicago. Dr. Padela is a clinician, researcher, and bioethicist whose scholarship lies in the intersection of community health and religion. He utilizes diverse methodology from health services research, religious studies, and comparative ethics to examine the encounter of Islam with contemporary biomedicine through the lives of Muslim patients and clinician, and in the scholarly writings of the Islamic authorities. Through systematic research and strategic interventions, he seeks to, one, improve American Muslim health outcomes and healthcare experiences, and two, to construct multidisciplinary field of Islamic bioethics. Dr. Padela.
Alaikum. It is truly an honor and pleasure to be here with you all this morning. Thank you, Gary. Thank you, Ahmed. Thank you, Leslie, for arranging all this. And I hope that you'll have some benefit. As it's interesting for me, I think that Ahmed, you've put together like the all-star team of Muslim bioethicists here today. So it feels a privilege, honor, but also anxiety-provoking for me as I sit in front of some people who I've interacted with over the years. I'll share a story of Professor Sajidina. Many years ago, when I was a medical student, I was interested in trying to gather all the information that there was on Islamic bioethics. And as I sat, this was in Qatar, as I sat there and I read over 2 months, I think everything that was available in the English language, I sort of wrote a paper saying that there was a lot of fiqh, there's a lot of law, Islamic law about this or that, the other things, fatwas. And there's some things about being a virtuous physician, adabi writings. But there was nothing else. And lo and behold, in 2009, Professor Sajidina wrote a book by Oxford University Press called Islamic Biomedical Ethics, where he talked about theological ethics, right? And so you'll see here in my presentation that I take that lead, that yes, we have a lot of fatwa and a lot of rulings, we have things about becoming virtuous physicians, but we miss this notion of where ethics becomes lived and practical through our theology. And today in this presentation, you'll see that I sort of take that arc from something that actually you started many, many years ago. So with that said, let's see, does this work? Maybe just this. Should I? Yeah, I did the arrows. Let's see this. Here. It's not moving. I tried to move the mouse, let's see. Then it does that. There, I'll use the mouse, it's fine. I'll use the mouse. I'm not sure what's going on with this. So I have no disclosures to present. I am supported by these three foundations to do work on Muslim health. As you heard, I have an active research program there, but nothing related necessarily to this presentation. And I think all of us are here today because we're thinking about medicalized dying, right? That the way that people make the transition from this earth to whatever lies beyond oftentimes occurs in this context, where they are surrounded by beeps and blings from soulless machines, and sometimes you even think that they are machines. They're not interacting with the world as we know them. And many of us in this room are thinking about how to become or reattach this notion, as you mentioned, of dignity, where we die around and surrounded by loved ones, where we are in our own place of sort of security, and that whatever lies beyond, we meet it in that sense of peacefulness. And I think that this conference and others like this are trying to do that. And this is what we're trying to deal with today, when this really dying has become very medicalized and has created a lot of interesting conundrums for all of us practitioners and administrators. But the larger scope of context in the public realm is that borders between life and death have been made fuzzy by the techno-scientific capabilities that we have today. We know in the medical care field that we can intervene, we can withhold, we can withdraw, we can sedate individuals towards whatever transition that we have. And the question for us as bioethicists is, should we? Right? And if we should, then how do we act upon that? How do we become virtuous in doing that? We know that, as Professor Sajidina and Al-Judi just talked about in their cases, that there's a lot of decisional impasses in clinical care at the end of life, right? What is truly shared decision-making? I would say in the ICU there's a lot of persuaded decision-making. That the way that you frame scenarios to individuals leads them to make certain decisions that you're okay with. And they only question their capacity or competence when they do something we don't think they should be doing. And this is the practical ethics of being an ethics committee member in the ICU. We think about surrogate decision makers, as you mentioned, right? So who is a surrogate decision maker? Should they be using the best interest standard, or should they be using substitute judgment? Or is there another notion within Islam about how we go about thinking about these things? And each decision has enduring repercussions, right? So some of the data I'll present to you later this afternoon talks about those health behaviors that occur after experiences that are negative in the healthcare system. So with that said, I lead this initiative, as Ahmed mentioned, that does research at this intersection between the tradition, biomedicine, and Muslim practices. We study how Islam influences the health behaviors of Muslim patients and how it might lead to some conflicts in the clinical arena. We study how Islam impacts the decisions and the practice of Muslim physicians. And we study how here medical imagination influences the writings of Islamic scholars. So we conduct empirical, textual, and theological research with the notion of reflexivity between the three to produce Islamic bioethics. And you'll see this presentation talks a little bit about theological ethics, but later on I'll talk about some of the empirical findings that we have from our work. So in this, here's the sort of the overview of this talk. And the first part, I'm going to discuss Islamico-ethical legal views on the moral status of seeking healthcare, provide you some scriptural sources and the juridical opinions around that. The second part takes that arc from legal to theological, talk about two theological constructs or the conceptual analogs within the tradition for human dignity and quality of life. And I'm going to argue that as far as it's related to the end-of-life care decision-making, the tradition gives wide berth and grounds for limited intervention. That an Islamic theology of care, using a Christian construction of theology of care, would focus on servicing the God-man relationship and building up human dignity near the end of life. And I think some of us forget that when we get wrapped up just in the legal aspects. So let's start off talking about those legal aspects. What's the moral status of seeking medical care through the Islamic sources? And I know that many of us are familiar with these, some aren't, so I'm going to be very brief but give you an overview of these sources. So in the Quran, for example, we have a verse that quotes Prophet Abraham saying that when I am ill, it is He who cures me, that when I am sick, it is God who cures me. We have various narrations from the Prophet in various canonical sources that talk about the commandment or directive to seek medical treatment. I've given you one here, one version, that he said, actually in command form in the Arabic, to seek medical treatment. For example, senility, or God has not created an illness except that He has also created its cure. And then there's another tradition that comes around when he narrates the people who will enter paradise without reckoning. He talks about a group of individuals that they have never allowed themselves to be treated by cauterization, which was a treatment at that time. Rather, they have put their trust in God alone. They're the mutawakkilun. Right? They are the ones who have this high station of just being trustful in God or relying completely on God. So these and other sources come together in the juridical mind, and there's a conversation that occurs amongst classical and even today continues in modern jurists about how do you reconcile a prophetic directive for seeking medical care with a known meritorious station of individuals who have abstained from medical care. In that context, right? At that time, this was medical care or one treatment. And then how do we reconcile this notion that we do things to individuals? We might think or talk about it lexically that we're prolonging life or we're doing something else or we're curing people, but the ontology of healing is that God is the one who brings about cure with or without human action. Right? With or without human action, an individual can be healed or cured. So how do you reconcile these? And the legal system then, and through theological sort of notions, comes up with some rulings. And I'm going to present a couple here. The general rule in Sunni law is that seeking medical treatment is permissible, right? Because you have to reconcile both. You can't say that if it was a directive only, that you have to seek medical treatment, you'd say it's obligatory. That's what the Prophet said. But then we have to reconcile this merit for abstaining. Right? And we know that some of the companions did not seek medical treatment. So the general rule becomes this permissible but non-obligatory, meaning that you will not be sinful should you not seek medical care. But it can become obligatory, right? And according to majority, when the proposed therapy is epistemically certain to save life. that you know certainly, right, or ghalabat al-dhan here, a predominant view, greater than 50%, as Professor Sajina said, that this is going to certainly remove harms of illness. So how does this play out? Within the four Sunni schools, you'll see that they all are agreed except for two things. I'll just point these out here. At the Shafi school, they say it's not just permissible to seek medical treatment, but you are given a degree above. It's recommended you get reward for doing that because you're living out his commandment, the Prophet's commandment. The Hanbalis, on the other side, sort of say that it's always preferable for those who can to just trust in God, taking the other narration. That is the higher station. That you can never make it obligatory because he's noted people who don't do anything are going to have this no reckoning to get into paradise. So you see the polls there, but the rest of the schools here classically have this permissible opinion. Now, moving to a more modern sort of context, right, the Fiqh Academy in Jeddah, this is specialist of Sunni jurists, and I believe there are Shi'i ones at that one as well, they sort of came up with an opinion that it's obligatory in modern day to seek medical care when neglect might result in three things. So again, this notion of death, when there's loss of organ or disability, so expanded beyond just death to now some notion of quality of life, as I'll talk about. But then they moved it to sort of communitarian ethics, right? When the illness is contagious, it's going to harm someone else. Right? If that's the case, you have Ebola or whatever else might be, and you're going to now cause harm in society, then now it becomes obligatory, meaning you're sinful for not seeking medical treatment. This is their opinion. It's not that they can contravene other opinions, but this is now how they have deliberated. And an actionable opinion is this one. So this, now what does this mean for us, right? Seeking medical care, or the implication of this restricted zone of obligation is that it provides multiple Islamic permissible courses of action. Right? When you make things obligatory in a restricted sense, everything else becomes, in a way, permissible. You're not sinful for doing or not doing. So there's a wide berth, right, as I said, for permissible options. It leaves room for personal values to impact goals of care conversations beyond religious mandates. Religion is not saying you have to do all these things. Oftentimes we imagine this is the case, but that's not the case. So now personal notions of what does my life mean to me, how do I think about it, do I want to be around when my daughter has a birthday or granddaughter is having this, even if it is in a very diminished condition, I can make those personal choices. And then this perception that occurs really, and I've noted this in the medical literature, this occurs a lot, particularly in cancer care, where people find that individuals who are very religious, right, or people who have religious support at the end of life, they end up doing a lot of feudal care. If you were to take this notion into the Islamic context, then those who are more religious or want to hold to these ethical legal views, right, they have a permission to forego as opposed to a mandate to seek. Right? Meaning that they should not necessarily have this notion that I have to do everything that we hear all the time on the wards. Now, that's the basis that I want to now start building upon. You might ask, in this context, well, if one of the conditions is that makes seeking medical care obligatory is that it's life-saving, well then by definition, isn't all life support at the end of life life-saving? So I'll address this tension at the end, yeah. So I will say, let's now move towards the encounter between physicians and patients and move towards theology for a moment. So the theological question would be, what is a life worth living? Or, in a medical context, what is medically worth preserving according to Islamic bioethics? So let's think about then, what is quality of life, or what is the purpose of life from our tradition? So you can find here that one of the integral purposes of life, as the Quran says, is that God, quoting God, I have not created man and jinn except for worship. إِلَّا لِيَعْبُدُونَ, or يَعْبُدُونِ if you continue on in the narration. So that I have not created them, mankind, except for to worship me. And there's a verse in the Quran that says, وَعَبُدُ اللَّهَ حَتَّى يَعْتِيَنَكَ الْيَقِينَ, that you should worship your Lord until it comes to you certainty, and this certainty is by the scholars of the text talk. This means the only certainty in life, which is that you will die. That you should worship your Lord until that event happens. Meaning that a life of utility in this sense is related to discharging religious duties. That you're created to worship God, to know God, right? And therefore that is a life of worth or merit. And when you move to the prophetic traditions, you see a similar notion here as well. So there are many, some reports here that there are individuals who come and ask about, who are suffering from ailments actually. One of them is a person who has some stomach ailment or diarrhea, and he's talking about, well, what can I make a supplication to end my life, or how do I deal with this? And so the Prophet responds that none amongst you should make a request for death. When any one of you dies, he ceases to do good deeds. And then pressing on, other people ask similar questions. So in another narration that says, none of you should make a request for death because of the trouble that he's involved. But if there's no other help to it, then you should say. So he gives them a supplication to make. Oh God, keep me alive as long as there is goodness in life for me, and bring death to me when there is goodness in death for me. Right? So the notion, as our beloved speaker said before, that this word uses khayr, that there's actually goodness in death. That there can be goodness in death. And this notion is one that informs the Islamic theological notions and legal notions of how we think about medical care. So again here, from these narrations and others, the life of benefit here now notes to relating to do good works, right? That it affects good works. That if you are going to depart this world and end this life, that then your grade in the hereafter cannot increase. That you'll be cut off from doing good deeds. So you shouldn't wish for that. So then taking these and other ideas together, you say, well, what is a maximal threshold quality of life marker, right? Not a graded one, but a maximal one. If you were to say that worship is the core purpose of existence, and that beneficial life is one that provides the opportunity to seek afterlife rewards. So within the Islamic law, we have a notion of an individual is morally liable in front of God. Right? And that's called a mukallaf. He has taklif. You have the ability. And what is that ability? That ability is a sort of a cognitive structure and a maturity of intellect notion, and there are gradations within that, that you're morally liable, you're accountable in front of God, that you're capable of recognizing God and recognizing the benefit and harms of actions in this world. That you have that intellectual ability, and therefore then you're liable. So the status is a potential status, right? Not everybody has it, right? Non-Muslim children don't have it. Non-Muslims, we won't say you're accountable to Islamic law in this sense anyway, right? But this is potential notion, and it's tied to a notion of maturity of intellect. And those who don't have such capacity for intellection, right? So those who have diminished intrinsic capacity, then just like the Bellman report talks about vulnerable populations, the Islamic scholars talk about the duty to protect that overrides. Right? That this is not some people with lesser quality of life. Rather, now we have a greater duty upon society to protect them from ills that happen. Right? The father has a responsibility now to take care of the children's wealth and do for it well. Make sure you invest it so that they have something after you leave, because of this duty to protect individuals who are vulnerable in that way. So playing that out now, you say, okay, well now, if there's setting for goals of care near the end of life, if there is an injury or an illness that does not threaten this potentiality, then from the legal rulings, there's no obligation for treatment, as I said, generally. Right? There's a conditional permission, and I'll discuss a little bit more what that means, but there's a conditional permission. Yet, many times near the end of life, you're faced with a notion that there is an illness or injury that does compromise an individual's potential for this this cognitive ability is threatened. So now your quality of life might be under threat, and our notion should be that we should try to restore that potential, that cognitive potential, as far as possible. Now, if that is not possible, if you cannot do so, then again, there is no obligation necessary for treatment, right? And there's conditional permissibility to do certain things, but you'll see that becomes restricted by these notions of dignity, as I'll talk about in a moment. Okay, so two broad guidelines, right? So I just took you from the theological standpoint. Now I'm going to mention to you that there are many juridical opinions about what you can do, when you can withhold, when you can withdraw, what you can and can't do. And if you take them summatively and say, what are the sort of ideas that come out from looking at this literature, there are two broad guidelines. One is when the clinical state, you can withdraw or withhold, when the clinical state of a patient is such that medical care is futile. They use many different words for that, and we know in the medical arena, when we talk about futility, two doctors can't necessarily agree what futility is or is not, but generally this notion of harms outweigh benefits, right? And that's one notion, and they allow the physicians to make that determination, or the patient to make that determination, largely. Or when individuals have some brain-dead physiology, right? When they are in this sort of state, this liminal state between life and death, they allow for withdrawal. So the obligation to initiate or continue life support then ceases to exist. Meaning, I start off saying that you say all life support near the end of life, therefore is certainly life-saving. But this is not the notion. That's not the logic that plays out, right? That these states are not ones that would say this is life-saving, because there's some diminished notion of what that life is. Or the harms are outweighing the benefits. So this mukallaf status notion that I presented as a quality of life measure coheres with the legal constructs of when you can permitted to withhold or withdraw life support. Okay, moving to the other concept. So now there's a lot of, and even you heard today, there's a lot of dignity talk near the end of life and in bioethics. Right? For some and this is various constructions. For some individuals, they say it's dignified because of the because of the highest intrinsic value that humans have, that we should do everything possible to keep them in any sort of state. Because any state of life is ultimate, it has the ultimate benefit. And that if we were to remove life support, you would then harm that intrinsic dignity. Others might say, what are you doing? This is not a human being. This is how would you treat people, right? In the same conversation based on their own intrinsic dignity. There are individuals who talk about, and we know this is the case in the United States, Brittany Maynard, I'm sure you have yours here, right? Where a dignified end, or death with dignity acts here, are that I can sort of control the time and the venue and within which I decide to depart this world. Right, so Brittany Maynard had a terminal cancer. She moved from one state to another that allowed death with dignity acts, where she could get assisted support and then choose a time. And she sent out an evite. Here's a time at this hospital, I'm going to take some medicine and I'm going to depart this world. Or I'm going to take some poison, some would say, and depart this world. But the notion here was that we're enhancing people's dignity because we're giving them control over their life. The palliative care movement also takes dignity approach, right? So you live with dignity, and we should think about palliative care, maximizing the dignity of human beings, as human beings, not as medical patients, right? And then there's some scholars like Ruth Macklin say that dignity talk is all religion trying to get into bioethics. There is no notion of dignity at all. It's just a word that we're playing on this word, and we're bringing in religious considerations, and that's how we talk about it. So one of my mentors, Dr. Dan Salmezi, talks about the topologies of human dignity within this context of bioethics. And he talks about three topologies here, or three types of dignity. The first being intrinsic, right? And this intrinsic is the worth of value that human beings have simply because they're human, right? It is of your certain kind of being, and that intrinsic dignity becomes you're that kind of being, that natural kind. It is attributed to all human beings in equal measure. There's no one who has diminished dignity. You're all part of the same humanity. And it's not diminished by illness, right? So not like autonomy is under threat because you're ill, right? You know, dignity is not under threat because you're ill. You're still of the same kind of being. There's attributed dignity, right? That is conferred upon others because of skills, virtue, power, position, right? So a ambassador comes in, or Justin Trudeau comes in, we'll say he's a dignified individual, right? Because he has some sort of position from some skill set or some votes that happened. And therefore, we give him or attribute dignity to him because of that stature. So it's created by some value of society, and it's always given and conferred by choice. And then there's inflorescent dignity, right? This is expressed in the behaviors, actions, or states of being that evidences and lives out practically that intrinsic dignity. And you say that this person faced that illness in the most dignified of manners, that they're living out the best qualities and virtues of being a human being and confronting that challenge. So these are the ways that we use it lexically, but also has different sorts of meanings. Now, taking that into the Islamic context, I would say that there are some homeomorphic equivalents or conceptual analogs to that dignity. And so I am going to now talk about those. There are two. One is karama, and the other is hurma. So karama, often translated as honor or dignity, is notion of an attributed dignity, right? That this dignity is conferred by God and given value because of this choice favor. And I'll show you the verse in a second. But it is attributed, not necessarily intrinsic, but you would say it's attributed in the heavens, intrinsic in this world. That God created you and gave you, because of your connection to Him, you have attributed dignity because you're close to God. Even the lexically in the Quran, this is the way it works out. But then in this world, you're the same kind of being. You're all humans, right? So all human beings share equally in this favor. You're all equidistant to God as His creation. Then the other notion is inviolability, hurma, right? And this has this, again, in the Arabic root, has this connotation of sacredness or prohibition. And it means that, you're inviolable. Right, that your property, your honor, all the things that relates to you are inviolable by other beings. The human body is sacred. Interestingly, as you'll see later on, this notion of the human body being sacred exists whether or not the soul is within the body for Muslims. Right, that there is still some dignity of the body, sacredness of the body, despite it being one that has no longer is the vessel for the soul. Okay, so in the scripture, I'm not going to exhaustively, but here's some indications that all three types of dignity that Dr. Salih talks about, lexically and typology, that typology is present in the scripture. So, for example, the first one, intrinsic, right? The Quran says, لَقَدْ قَرَّمْنَا بَنِي آدَمَ, that we have honored the children of Adam. Look at the word, children of Adam, right? Human beings. It doesn't say this group or that group, and it's from God. We have conferred dignity upon human beings. The prophetic narrations talk about attributed dignity in this way. There's one hadith, إِذَا أَتَاكُمُ الْكَرِيمُ قَوْمٍ فَأَكْرِمُوهُ, that when a person of an individual from a certain status, from a certain tribe comes to you, right, a dignitary from that tribe, then you give him that right of being a dignitary, right? So there's a positive right that comes out of attributed dignity, and there's also an intrinsic negative right of dignity. So قَصَنَ عَظَمِ مَيِّتْ كَكَسْرِ حَيًّا, that breaking the bone of the dead individual is like breaking the bone of the one who's living. As I said, even after the vessel no longer holds the soul. So that leads to negative rights of inviolability. And then in terms of fluorescent, and I want to share just a few snippets, I think, and I won't have time in this talk to talk about them, but I think for us, when we think about restoring a notion of a ars moriendi, right, an art of dying for Muslims today, that we have glimpses of that from the prophetic way he approached death, right? And here's just three notions. That, there comes to us the various, in the last days of the Prophet's life, we know of a story where he goes to the Jannat al-Baqi, he goes to the cemetery, and his servant is with him, and he's heard making some conversation, and the servant didn't overhear. He comes back, tells the servant, well, what would it be if I told you that, that a servant or an individual is offered to be, to stay in this world forever, or to be with God. And, all right, well, and that servant chose God. So now that's not what exactly he said, but this is the relation that comes back to us, that he chose and selected leaving this world, not being here permanently, to be with Ar-Rafiq al-A'la, the highest companion, as he called God, right? That you're selecting accepting death. That he, near the end of his life, there was some companions who wanted to give him medicine. He falls into a state of unconsciousness, and someone sticks something in his mouth, and the one narration comes as his wife. And he gets up from that state, and he says, he's upset. And he says, well, should I put this in your mouth? Again, not the words he said, right? But this is not what I wanted, right? I don't want this field of medicine. I have already chosen death, or death is coming, right? I don't need the doctors to come. Or really now the final moments that comes to us that he's making prayer, he's leaving this world in and out of consciousness, and a brother of one of his wives comes in, and he's using a toothstick, right, to clean his teeth. And he makes some notion, the wife says, oh, I think he wants that. So she moistens it and gives it to him, right? And the last thing that happens, and they talk about, is that his teeth are being cleaned because he's going to meet God, right? This decorum or dignity of being a human being. So here, and fluorescent dignity comes about. How is he approaching that? And for a modern ars or moriendi, for us as Muslims, I think this is a treasure trove to mine. So back to karama and hurma for a second. The implications for end-of-life care here are thus: that karama makes us focus on the God-man relationship of dependency to God, right? Equidistant from God. That we should be thinking about providing spiritual support. And then this notion of seeking to preserve consciousness, right? As this notion that this is mukallaf status here, that the condition for worship and spiritual practice is that you have an ability to recognize and participate in that relationship with God. Hurma, again, now implicates cautious approach to invasive interventions, right? To protect bodily dignity. And that then after death, there's postmortem or examination are restricted. Some jurists actually use that snippet, that hadith of breaking the bones of the dead is like breaking the bones of individuals, to prohibit actually categorically organ donation. Now, I'll skip that one. So a theology of end-of-life care here, building upon this, tying the two things together, this sort of notion of quality of life as mukallaf status and this notion of dignity, then the goals of care is to maximize the chance for an individual to regain the status in case where an individual was formerly mukallaf status and has lost his capacity due to illness. And to preserve the cognitive function of this individual, right, to become mukallaf in the future. So this now expands to everybody, not just that specific individual. And in terms of guidelines, we should consider the harm-benefit of proposed treatments in relation to the hurma and karama of individuals, right? That every intervention in some way breaches the inviolability and sacredness of a human being, right? That even just that body. being in the hospital can be an indignity to some individuals. If you ask my mother when she's in the hospital, she doesn't want to be in the hospital ever, right? Or my wife, these sorts of things can create a sense of unease. And that there should be an intention to the God-man relationship and spiritual support, as was mentioned before. So my further counsel here, and I hope I've left some good time for conversation, is that as providers, we should be thinking about building up the inflorescent dignity at the end of life through spiritual support. How can individuals meet this? And some people we know, right, don't have a lot of time when they are in the ICU. How can we make them live those moments in the most dignified of manners, and sort of not have them suffer the dignities of being in the hospital, removed with these soulless machines beeping around them, right? And should we, and this is now a controversial point, but should we be counseling individuals, and maybe not physicians, maybe this is the role of the spiritual, of the chaplains, to counsel, set right affairs of their world. Individuals who have had not talked to their brother or sister or mother or daughter for 25 years, perhaps it is time to make your peace with them. Or have a good opinion of what's coming next, right? There are people who have spiritual distress at the end of life. This is part and parcel of the terminal notion to terminally sedate individuals to death, right? Existential pain and all these things. Perhaps we should be talking about having a good opinion of what comes after. And this is actually, there's a hadith to this effect. And then we should respect and acknowledge people's human dignity, right? We all share in this at least intrinsic notion of dignity. We should act in accordance with dignity, right? And this illness does not lessen this notion of dignity at all. Right? So as I said, sometimes when we say indignities in caring, there are indignities in caring, right? And you can see that some people are just very, very ill at ease in the hospital setting. So, and I know this is all part and parcel of palliative care, but I think this gives us another notion to think about. We're actually trying to enhance, right, the intrinsic dignity of individuals as we move forth in proceeding to provide care for them. So with that, I hope I left good time for conversation. Thank you.
Dr. Padela, thank you very much. I really enjoyed your presentation. Several elements, you've covered a lot of ground. I have a number of questions, but I'll just start with one, and that is the notion of futility. And it can open up a can of worms, I know, and there's many opinions. I want to focus on one thing you said, which is the definition of futility, although there's a lot of nuances, we would accept a working definition where there are many more harms than benefits of a proposed treatment. And so my question to you is, can you expand upon what harms, from an Islamic theological perspective, one needs to consider? For example, financial harms to the family, suffering, because we've heard that there is goodness in suffering, and other potential harms from hurma and karama perspectives. Which of these do we weigh? And then more importantly, how do we weigh them against the idea of being able to continue to worship Allah because we remain alive? Right. And I know this is not an easy question, but I would appreciate some insights.
I wouldn't expect an easy question from you anyway. Very good. So let's take the first part and the second part later. So I think that this, and maybe I misspoke, but in terms of futility, there's physiological futility. All right. So that if I give someone if I put them on Levofed, and I want to see their blood pressure rise, right? Then I would say that Levofed is a vasopressor, and so in the sense that if I were to do that, I would see their blood pressure rise. There's no physiological futility in giving the person Levofed. Now you might say there's medical futility because that blood pressure rise is not going to equate to any sort of cognitive betterance. Yeah? So my point being that the way that we use the term futility has many different gradations. And so near the end of life, when we talk about, and forget about physiological futility, when we talk about efficacy of treatments, the jurists talk about, and this is not, that certainty about removing illness-related harm. So for example, you could say that pain is an illness-related harm, right? And can you have certainty that giving some medicine is going to reduce that pain? Now, I use the word pain because we now know, we've expanded upon what that pain would be. Meaning some of us say that their pain, right? This notion of pain as a fifth vital sign that everybody in the hospital comes and gets this pain. So what pain are you talking about psychological pain, spiritual? Are we trying to sort of now, we've now expanded the notion of suffering here, but pain used to be something that we can't know except for the subjective person tells us. But then we started developing tools to assess pain scales, Vinal-Agilal scales. Then we said, oh, there's some blood pressure. Maybe there's some correlation to stress markers in the body. So my point only became that we medicalized and biomedicalized pain, and now there was a problem there, so then we moved back to suffering. We want to now treat suffering. But then this notion, as you said, comes in. So I'll answer your question with this after this sort of spiel. So then the suffering business, for me as an observer here, becomes something that we say, well, there are people whose restitution at the end of life, as Dr. Al-Judi said, that who have a recognition of perhaps they're in depression because they realize they spent their life in worthless endeavors, is actually okay. And that has some benefit for that individual. It is not suffering. Right? So we came back to now a subjective notion of suffering. We said pain was subjective, let's sort of think about it making more objective. Then we said there's a problem here, then we went back to suffering. That became again subjective. And then we say now we have to minister to the suffering of individuals. I'm not sure medicine ministers to the suffering of individuals, I'll just tell you that. So I think that the language that we've used has been used for strategic deployment in argumentation and polemics. Dignity, death with dignity. Aid in dying versus assisted suicide. For polemical policy purposes, not to tend to the individual in front of you. So in terms of harms and benefits from a legal perspective, from the Islamic, there are, as you open the door, so there's an entire chapter within our legal text about what we would now call the law of balancing. How do you balance removing harms, right, with bringing about benefit? And what is first and what's last? And removing harms comes over. Awla, muqaddam, and jalb al-masalih. Right, that it comes over predominance over bringing benefits. But when you see that specified within juridical rulings, right, there is a subjectivity to the individual who is morally liable. So we might say it's permissible or obligatory to remove suffering, but the or pain or whatever you say, but the individual is culpable, is the one who's morally liable. Therefore, the subjective opinion of what that is one that you take. However, you're not obligated to agree with that notion. Meaning that this comes about in aid of dying. So people might say, I want to be terminally sedated. The scholars, in my reading, the scholars have not yet said, Sunni, Shi'i, modern, classical, that this is permissible. They might say this is suffering for me, but Islamically, we're not obligated to now develop that notion. They might have some way to think about what I want to do. They might be fine. But you as a physician third party are not necessarily tied to their notion of suffering because it is subjective. And here the harm would be that you are doing something for your own harm, not their harm. Because we know killing someone or assisting killing someone is going to have an effect on your afterlife. So now the notion of harm is your harm. Forget about their harm. What harm am I doing to my afterlife? So I think that, and I'm sure in the discussion we'll expand about this more, but I think that this is where the crux lies, right? When you're bringing a modern notion of harms or benefits, right, to other ideas of suffering and pain and then you're saying, let's see what the legal tradition says, when the vocabulary is very different culturally. And so I don't have a cut and dry rule for you, but I will tell you that what we have are limits where we think about the individual and that subjectivity for the individual, what they want to pursue. Now, it doesn't mean that the state or the physician has to provide that, because they have to think about their own harms and what might occur with that action. But there aren't cut and dry rules about, okay, this is harm or not. Anything, even a pinprick is harm. Removing that harm might be obligatory in certain cases, and others is not. So a roundabout answer to this subjective question.
So I have a question. You talked about... So we're talking here about the theoretical concept of dignity. But we know that Muslims comes also from different backgrounds, diverse backgrounds, different socioeconomic status, and so many things that may also contribute to the concept of dignity. So how do you think this concept, is it generalizable to all Muslims? And how can we like have a better understanding that for Muslims in general. I'm looking at understanding that embrace religion, culture, family, and all other variables.
So what in this slide here, oh, sorry, I don't know what I just did. Forget about the slide there. Okay, so the common denominator for Muslims, whether they be Sunni, Shi'i, progressive, liberal, whatever, it's conservative, and you ask them what is Islam, they'll say, well, Quran and Sunnah, right? Quran and Sunnah, Ahl Sunnah wal Jama'ah, right? So that in some, that's how the Sunnis are appropriated that, because everybody's agreed that the Quran exists, this is the Quran, and that there's a prophetic notion. And so what I was saying was that in the scriptural text, you can see that all this typology of dignity, if you're going to map onto a tradition that has different words, hurma, karama, that these notions that we talk about today in bioethics of dignity all are present there. And Muslims, by and large, right, you might say that we don't agree with this hadith, this is weak, or this is not from our tradition, we have another set of hadith, all right? Or this Quranic verse can be interpreted differently, so we have plurality. But when you say these are what this is what the revelatory guidance gives us in terms of notions of hurma, inviolability, and of karama, and of dignity of human beings, that they would say this is of value. Meaning that this is the common locus of what is, these are the common sources that actually construct a Muslim identity. The Quran and Sunnah notion, right? You might say, I don't believe, so fine, this is what the Quran and Sunnah says. I don't care what the Quran and Sunnah says. That's fine, but they won't say that is not what Muslim nature is, or that is not part of Muslim discourse, or that is not having some normative value. Either if you might not agree that for me this makes any sense. I don't care what the Imam says or what the Quran says or anything else. But my notion of Muslimness does reside within these, right? That my information of what Islam might say, or how I form my Muslim identity would be between these sort of scriptural sources. I might disagree on the hermeneutical theory which they applied. So I'm answering your question about, how do we say that there's so many different views, Muslims might come with different notions of dignity. Yeah, I'm a physician, I was born in the United States, and my notion of dignity, what dignity is, that term doesn't come to me through the Quran, comes through me through my interactions with society here, right? And I'm mapping on to that tradition what I think about here. I was informed that here's what dignity means, and no one in school told me what dignity means, but the culture and society informed what dignity might be, or my medical profession might be. But when I'm thinking about the Islamic or Muslim notion of my part of me, then I say, well, what does the Quran and Sunnah tell me about these ideas? What can I find within that tradition that helps me understand, as not being a person who's schizophrenic, I'll use that term wrongly because I'm a physician, I know, but as having split identities between what my convention, medical convention tells me and what my religion tells me. So I'm trying to make those bridges. But to your point, I think that if you were to find any Muslim, and you say, here are what some notions from the text of what these concepts are, that they would say, yes, those are Muslim notions. Now, I might not agree that this is for me as a Muslim, but okay, they're within the universe of the discourse that is of an intellectual tradition and a civilization. So that's how I would say that. And our challenge as healthcare practitioners is the opposite. Meaning, we might say that we understand what Islam says, but I don't know what the Muslim says. Right? I might come to Sajidina, Professor Sajidina might say, here's what Islam says. Okay, that's what Islam says. But this Muslim in front of me, I don't know what he wants. And that's where there is, right? So theory, as you said, to practical, right, to pragmatics at the bedside. And I think that's fine. And they might say, I don't care. But you can say, here, if you want some guidance, here's what some people who are authoritative in your tradition say. If that is of value to you. If it's not of value to you, fine. No problem.
I'm just going to share my experience and not necessarily asking for clarification. I have been working as a chaplain in one of the local hospitals here, it's a kids hospital, for the past 20 years, and I got my pin for the 20 years working there a few months ago. It's very interesting, very beautiful presentation, very insightful. You've gone to many resources and got the theological, ethical perspective. But from my experience working on the ground, dealing with patients, I have found it always challenging for patients and family. And my work primarily has been with families who's dealing with their sick patients, children. Not necessarily dealing with the ethical with the emotional, with the theological, but more with the emotional. And as I have attended many rounds with the palliative care department at SickKids, which is very active and educational department, in the past two rounds that I have attended, one of the presenters was from Mexico, who was a student coming to Toronto here for, certain program, and his presentation was the interpretation of a different language, and his presentation was an eye opener for me to look not only to the patient side, but also to look into the physician side, the team who are working with patients, and the struggle which you highlighted on, the struggle that the staff would be dealing with as they're dealing with a patient at the end of life, process. And I hope that as the discussion goes with this conferences, we're able to come to terms from practical perspective, because many of us are familiar with the texts of the theology and the principles and the ethical issues, but rather how to get them on the ground, because the challenges from my perspective that I have been dealing with are the life versus end of life, and quality of life versus life, and the acceptance, or not acceptance, but the finding the middle ground where you're able to help family or a patient accept certain decisions, and at the same time make the staff able to deal with that decision, because this is very challenging. And as I said, from my humble experience, it's been very challenging, because what families call for when they ask for the imam or the chaplain, or when they have a discussion with the medical team, is to find an easy way to take a decision that would not make them feel guilty as they walk from the hospital at the end of whatever it's going to happen. And at the same time, the staff, as they're dealing with this patient, at the end of the treatment or the end of life of that patient, they would continue to do whatever they're expected to do, not walking with heavy burdens of, I shouldn't have done that, or have done something that are against my own values. Exactly.
So, thank you for that insight, and I fully agree with you. One of the individuals who I look up to makes a comment. She's a nurse. She makes a comment that and she deals a lot with these transcultural challenges in healthcare, and she's a Muslim. She sort of says, right, that whatever happens in that encounter, you recognize that the people who are leaving the hospital are the family. That you will come back to the hospital as a doctor tomorrow, right? And you will go about your practice. That patient may not leave the hospital, meaning, right, as an individual, he might pass away, but the family is leaving. And what ends up happening is that we forget them as moral agents, right? That they might have guilt, they might have spiritual suffering that comes about, and we don't tend to them enough. And so I think that you're absolutely right, that what ends up happening is that what we should be focusing on is pragmatics. And as an ethics consultant in our hospital that sees a lot of international patients, the top 4 populations in the University of Chicago internationally are Muslim nations. And I get pulled in, and what people want are outs. So if there's a juridical opinion that brain death is death, although I don't agree with it, I understand there's plurality in Islamic law, then okay, we'll do that. Just give me an out. Find me a heuristic and a logical pathway of which I can get an out in this. I don't, right? Because physicians are not willing to, and this is the problem. We often want to engage them because we want our own consciousness solved. It's autonomy is king. They say do it, we're okay, right? But when we say they say do it, now they're like, I need an out. Because the doctor wants me to say this, and I don't know how to get there. Can you help me get there? And this is a benefit of our tradition, that there's plurality. And this is why you have many thousands of fatwas, right? They're dealing with the real issue on the ground, and they're trying to solve that spiritual crisis of that individual, not coming up with some meta theory of Islamic bioethics. But at the same time, what ends up happening is that I would say, and you'll see my next presentation, that we actually are not versed in the heuristics to give them outs. Meaning we as Muslim physicians and imams on the ground, right, and people who want to be up here and talk about things, that we don't know enough to give them those outs. So the responsibility is on us to learn. to give them the house. Like, I'm not going to come up with a meta theory of Islamic bioethics. I'm not. Yeah? But I'm going to tell you something that may be of use to you, and then I, tomorrow, in my encounter, can help the patient, because that's who I'm serving. Or the physician who's conflicted. That's all I hope for. And as a physician, this is why I'm in this game, because I find myself conflicted, and I need to know. So I think that's why your assumption that we know, I think that is not the case. But at the same time, we are dealing with pragmatics, not theory building at the bedside. And so we need to think about that, right? And understand that our notions of what we're doing are to help solve a problem that's occurring. So anyway, I wholeheartedly agree with you. I think I'm taking too much time, and I'm sort of like, going on and on. So thank you for the time.